Hi, everyone, and welcome to the Parkinson's Disease Symposium brought to you by IU Health and the Parkinson's Foundation. Thank you so much for joining us today. My name is Jessica Bartsch, and I'm the Community Program Manager of the Midwest chapter for the Parkinson's Foundation. Before we get started today, I will share some information about the Parkinson's Foundation, followed by a brief welcome from Dr. Elizabeth Zauber. But first, let's take a look at our agenda. Today's program, we will discuss what's on the horizon, the benefits of art therapy, exploring OT, PT, and speech therapy for Parkinson's, a discussion about motivation and PD with a focus on apathy and impulsivity, and lastly, followed by a Q&A panel with our presenters. Please note this program is being recorded, and a follow-up email will be sent to all registrants in about 7 to 10 days. In the follow-up email, you will receive a link to the recording of this program, as well as information of resources discussed. Also, please note, feel free to submit questions at any time by clicking on the Q&A icon located in the black banner on the bottom of your screen. Again, we will do our best to answer as many of those questions as we can. The mission of the foundation is essentially to make the lives better of anyone affected by this disease. Whether you are living with Parkinson's, caring for someone with Parkinson's, or working to end this disease, we are here to support you. To support our global community, we focus on 3 goals: improving care for people living with PD through centers of excellence like IU Health, advancing research toward a cure and investing in the brightest minds, and empowering the community with educational resources. The Parkinson's Foundation has a wide array of free resources. We have educational books, a podcast, our Aware and Care hospitalization kit, a helpline staffed by experts, our website parkinson.org, and more. I also want to share some exciting information about our national initiative, PD Generation. Did you know the foundation is offering genetic testing at no cost for people with a PD diagnosis? Participation can either be in person at one of our participating centers of excellence sites, like here at IU Health, or now from your own home through a telemedicine appointment and an at-home cheek swab kit. To learn more, please visit parkinson.org/PD Generation. Lastly, I want to inform you of our wonderful virtual series, PD Health at Home. Through PD Health at Home, we provide weekly educational and wellness programs that focus on mindfulness, wellness, and fitness. And I'd like to highlight a program coming up through PD Health at Home next Wednesday, March 16th, titled PD Solo, Living Alone While Living with Parkinson's. This webinar will focus on reducing isolation, intimacy and chronic illness, building friendships, and how to be alone but not lonely. To learn more or to register, please visit parkinson.org/PD Health. And now it's my pleasure to welcome Dr. Elizabeth Zauber.
Hi there. Thanks for joining us. This is our annual symposium, and we're so thankful for the support from Jessica and her team for putting together this virtual program. It actually takes a whole lot of work to do a virtual symposium and make it go smoothly, so many thanks to them. There are, of course, many advantages to the virtual format. I assume most of you are at home in the comfort of a comfortable chair, and some of you are joining us from across the country, which we're very pleased about. But we do very much hope to be in person next year to meet face to face, and so we look forward to that. One of the things I really enjoy about the work that I do is that I get to be part of a really wonderful team of professionals who help care for people with Parkinson's. This allows us to provide really good care, but it also means that I get to learn from them every day. And so I look forward to you learning from my team today. And I'm going to introduce our first speaker, who's Dr. Chris James. Dr. James is one of the movement disorder doctors that's part of our center here at IU. He went to medical school at IU, and then he went to New York to NYU for neurology residency. He came back here to IU for his movement disorder fellowship. He serves as the director of the Huntington's Disease Center of Excellence. However, he spends most of his time seeing people with Parkinson's disease. Welcome, Chris.
All right, thank you, Liz. Hopefully everybody can hear me okay.
We can hear you, Dr. James. You can start to share your slides.
Okay. Can you see that?
Yes.
Yes, thank
All
you.
right. Okay. So, yeah, thank you everybody for attending this today. I think the goal of what I'm trying to kind of get across today is just giving you just a little information on some of the newer medications that we have at our disposal that have come out in the past couple years or so. And then I'm going to get into kind of what's new in particular with research, in particular disease modifying therapies, and what may be available currently now for patients that are interested in possibly getting involved with some of these things. Some of them are available here in the United States. Some of them, there's one in particular that I'm going to highlight that's available at IU right now, and we would appreciate anybody's assistance in trying to help us out with that research project. I'm not going to get into any new things with regards to deep brain stimulation, although there have been some interesting developments with deep brain stimulation in Parkinson's disease, but it's mainly going to be geared towards medications and potential future medication. So these are some of the newer medications that are available to us that we can prescribe today. A lot of you will probably recognize some of these, and potentially, you know, we may have tried some of these in the past. A lot of these medications are related to they're trying to reduce off times in Parkinson's disease. So I think it's worth mentioning or kind of going over exactly what that means. So there are many patients with Parkinson's disease that have a positive response to levodopa, also called Sinemet or carbidopa. And that's great. That's great that they have a response. But as time goes on, when a Parkinson's patient progresses in their disease, their ability to make dopamine themselves gets less and less. And so in response to that, we usually need to increase the frequency or the amount of levodopa that we're prescribing someone, because it's essentially a dopamine replacement therapy. So that's great in that we have a medication like levodopa, which is helpful. The problem is that when you are taking levodopa, you're relying more on it, then you're at the mercy of its half-life. And so the half-life is around officially kind of like 90 minutes. So that's not very long. And so what tends to happen for a lot of our patients is that you end up having significant fluctuations in the day. So the concept of on time is when you take your medicine and you feel, for a lot of folks, that the medication has started to, quote, kick in. They note like a change in how they feel or how they think. And then on the flip side of that, a lot of patients notice that the medication starts to wear off. And so when that happens, that's called off time. And so this is just a picture essentially as time goes on, that our clinical effect of levodopa has a shorter window of time than likely in earlier Parkinson's disease when you first started taking levodopa. So the goal of these medications is that we want to keep you in that on-time state. So the first one is Kenmobi. Kenmobi is essentially apomorphine. It's a sublingual film, and it's used as a rescue medication. It's a dopamine agonist, but it's slightly different than a lot of other dopamine agonists that we use, that have been used in the past, including things like Mirapex and Requip. This is a drug that sometimes can be helpful for folks, especially if they have sudden off times. They can stick this film underneath their tongue and it dissolves. And usually people can get sort of back into that on-time state, usually within about 10 minutes or so. It can cause some dry mouth. Sometimes people feel like the film itself can be a little irritating underneath the tongue. It can also cause some nausea, and so those are some of the things that we run into. It can cause some blood pressure fluctuations, like a lot of Parkinson's medication. But it's nice that this is at least an option for us, for our patients that have, especially times where the medication feels like it suddenly kind of stops working. Ambrosia, this is another one that's considered a rescue medication. So this is a capsule that you put into this device, and you press this device together, and it punctures the capsule, and then you take this device to your mouth and inhale. It's kind of like an albuterol asthma rescue inhaler. So this is levodopa. It's the same medication as what's in our regular carbidopa, levodopa, Sinemet medicine, but because it's inhaled, it gets into the lungs, and so that's a faster way of absorbing the medication. This is not meant to replace oral agents, just because you would have to be inhaling this stuff all day long, which nobody wants to do. So this is to supplement oral medications, and again, it's considered a rescue therapy because of its quick onset. Okay, coffee. Okay, Norians. So this one is a little bit different than our typical dopaminergic therapy because it has kind of a novel mechanism than what we usually use. This is an adenosine receptor antagonist. And it modulates the dopaminergic system, but it's not a dopamine replacement kind of therapy. So it acts on off times, but it does so in a slightly different way. The main side effect of these medications, the next couple here that I'm going to talk about, is that it tries to treat off times, but the downside is that you can create too much on time. Okay. And I guess what I mean to say by too much on time is you can have too much of a heightened effect of the dopaminergic system, which for some people means worsening dyskinesias. So for some folks, on time is synonymous with a time where they have dyskinesias. For people that are not familiar with dyskinesias are involuntary movements as a result of having Parkinson's disease and being exposed to additional dopamine therapy. And not everybody gets dyskinesias, but it does happen for a large number of people, and it usually occurs in patients on times. So if you have too much, if you're stimulating this dopamine system too much, then you can get worsening dyskinesias. So that's the main side effect of Nourians, as is Ongentys. This is a medication that's similar to one that we've had for quite some time called entacapone. For folks that take entacapone, this is something similar, but it's like a long-acting form. It's a COMT inhibitor, once daily, reduces off times. And again, the downside in treating off times is that you can swing kind of too far over on the pendulum to the other side, and it can cause worsening dyskinesias. The Dago, again, once daily, treats off times. This is an MAO inhibitor. We have some of these medications available to us already, but this treats folks in a slightly different way. And again, the downside here is worsening dyskinesias. So who are these medications for? These are medications for people that have a positive response to levodopa, but it just doesn't last very long. And so these are folks that likely are taking or having to take their Sinemet, 5, 6, 7 times a day. And because if they don't do that, then there's too much of that off time. If somebody is fluctuating that much, and during the times they are on, they're having significant dyskinesias, these are also medications that you would need to be careful with because of the possibility of worsening dyskinesias. Okay. So I'm going to go over a couple of alpha-synuclein tests. The SynTap is a test that looks at alpha-synuclein in blood or CSF. The SYN1 test is a skin biopsy. Let's see if So briefly, alpha-synuclein is a pathologic, we think, is a pathologic protein that's found in brains of Parkinson's patients. It clumps together, as you can see in this picture, and it creates what's called a Lewy body. So for quite some time, people have been wondering, what happens if you reduce alpha-synuclein, and we'll get to that in a few minutes with some of these potential treatments. But what I want to talk about here is testing for alpha-synuclein. So this would be a way that we could potentially identify patients with very, very early Parkinson's disease, potentially before much more significant symptoms and signs occur that we'd be able to evaluate in the exam room. So right now, for most of you, if you've been diagnosed with Parkinson's disease, you know that the diagnosis of Parkinson's disease is basically us just saying, yeah, you have Parkinson's disease. And for a lot of folks, that's kind of frustrating, because you're like, well, isn't there some sort of confirmatory test or something like that? There are some imaging studies that we sometimes use, but they're not great. And so most of the time, it's something that we just diagnose in the office, and it's dependent on kind of what we see, the signs and symptoms that you're telling us about, and then your history. So it's known that cell loss in Parkinson's disease begins decades before motor symptoms develop, and that oftentimes non-motor symptoms appear first. So people have been trying to find ways to diagnose Parkinson's disease earlier. The idea is that, you know, a lot of these treatments that are being looked at right now, they're likely going to be more important for folks with earlier disease than with later disease. The brain has limited ability to reverse damage. We know that the brain does have an ability to do that, but the brain can be quite stubborn in terms of its ability to heal. And so it's much easier to stop damage occurring to the brain than once it's already occurred, try to reverse the damage, if that makes sense. So a lot of these tests are designed to try and identify folks with much earlier disease so that we can kind of identify them and potentially, hopefully in the future, have a disease-modifying drug or treatment available that we can give them and prevent the damage that otherwise would have occurred. So the SYNTAP test. So again, a lot of us feel like, a lot of researchers feel that alpha-synuclein is that at the heart of Parkinson's disease, or at least it's a very important component. And so these tests are basically looking at trying to find alpha-synuclein in different parts of the body. Clumps of alpha-synuclein build up in the brain. They interfere with normal functioning of brain cells, and we think, it eventually causes cell death. This process of misfolding of this alpha-synuclein, it happens and occurs decades before the clinical symptoms of Parkinson's disease. Oftentimes people start to develop, let's say, constipation or changes with their sense of smell, or even have what's called REM behavior disorder, where they act out dreams years and years before they ever developed sort of stiffness or slowness or tremor. We now know that in folks with Parkinson's disease, alpha-synuclein, it can be found in the brain, obviously, but it also can be found in cerebrospinal fluid and blood. And so this may be able to be used as a biomarker for early diagnosis. One of the problems with using this, in particular with the SYNTAP test, this is a test, again, that you can send, that physicians can send now. I should note that none of these are technically FDA approved. So they have not gotten FDA approved yet. They're in the process of doing so, but these are tests that we can do now. But they're going to be out of pocket tests, so they're going to be kind of pricey. I think the SYNTAP, I want to say, is around $1,500 last time I looked. So the SYNTAP test, this is basically trying to find alpha-synuclein in different parts of the body. In particular, you can do it on blood or cerebrospinal fluid. Cerebrospinal fluid would require a lumbar puncture or a spinal tap. Usually you can get more alpha-synuclein from the cerebrospinal fluid than you can with the blood. SYNTAP has created this system of basically amplification of any existing alpha-synuclein that's in the sample. It amplifies it before it identifies whether it exists. And the reason why they do that is because alpha-synuclein can occur in such small amounts that you would never be able to really identify it. So in order to test it, they have to amplify the existing alpha-synuclein. And so that's sort of the magic of that test, is they developed a way to kind of amplify any alpha-synuclein that's present. Amprion is the company that's doing the SynTap test. This test is 87% sensitive, so which means out of 100 people with Parkinson's disease, 87 will test positive using this test. The rest, the 13 others, will have a falsely negative result. It's 97% specific, so which means out of 100 without Parkinson's disease, 97 will test negative. So it's not a bad test. It's pretty decent. There's no perfect, absolute perfect test that exists that's 100% specific and sensitive. But it's not bad. And again, last time I checked, it was about $1,500. Of note, both of these tests can distinguish whether or not misfolded alpha-synuclein is present, but it cannot distinguish Parkinson's disease from dementia with Lewy bodies and multiple system atrophy. So if most of the folks here probably have or know somebody with a Parkinson's disease diagnosis, there are a couple of other diseases that we run across quite frequently, including dementia with Lewy bodies and multiple system atrophy. And both of these other diseases as well have to do with alpha-synuclein. They're called synucleinopathy. So the point is, if you had tremor, this would be one way potentially of differentiating essential tremor from Parkinson's disease, but it wouldn't be able to distinguish Parkinson's disease from multiple system atrophy. The SYN1 test, this is a skin biopsy. It's a little bit more invasive, but supposedly, according to the company, they said it's 95% sensitive and 99% specific. As is with the SynTap test, the SYN1 test would not be able to distinguish between Parkinson's disease and multiple system atrophy or dementia with Lewy bodies. Okay, so these are some future strategies that are being looked at right now and are currently in phase 1, 2, 3 trials. So there's lots of different strategies being looked at to treat the underlying disease of Parkinson's disease. And so we're not going to talk about all of them, but I thought at least these 5 can cover quite a bit of ground in terms of exciting potential therapies in the future. So one, we've talked about alpha-synuclein. What happens if you target the aggregation of alpha-synuclein, if you try to get rid of alpha-synuclein or prevent the development of alpha-synuclein? So what does that do for the development of Parkinson's disease? LRRK2 is our most common monogenic form of Parkinson's disease. What happens if you reduce the activity of LRRK2? Glucagon-like peptide 1, this is a strategy that potentially could be used to block the activation of immune cells in the brain. GBA, or glucocerebrosidase, what happens if you increase the garbage disposal system of the cell? And then GDNF, what happens if you actually directly inject growth factors into the brain? So this is a representation of how difficult it is from the point of discovery of a drug compound into making it something that's actually FDA approved and something that we can prescribe. So of all the drugs that we're going to talk about or compounds, we're going to be in the clinical trial phase 1, 2, or 3. So it's gone through drug discovery, preclinical stages. So it's already made quite quite some leaps to get to the phase trials, but still, just because it's in a phase trial doesn't mean it's necessarily going to be FDA approved. So the top half of this circle are disease-modifying therapies that are being looked at right now. The bottom half are symptomatic therapies. I'm going to focus on the disease-modifying therapies because they're just more exciting, and they have a potential. The idea is that there's a potential that it could actually slow down the progression of disease. Whereas, all the therapies that we have available now for Parkinson's disease are considered symptomatic therapies. They have not been shown to reduce the progression of Parkinson's disease, but instead just treat the symptoms. So we're going to focus on the top half here. So first, some alpha-synuclein strategies. People are utilizing immunology to try and combat alpha-synuclein. So there is a passive approach to treating alpha-synuclein. There's what's called an active immunity approach. And then there's some other compounds that kind of block the aggregation of alpha-synuclein. So passive immunization, the most common passive immunization is obviously with maternal antibodies, but as you can see, this guy that's in the shadows here, he's getting some antibodies that are being delivered and infused to him. And these antibodies, the idea would be that they that they bind to alpha-synuclein, and then your body starts to dispose of the alpha-synuclein protein. This is a representation of active immunization. So instead of me giving you an antibody that binds to alpha-synuclein and you get rid of alpha-synuclein, I give you some drug that your body then responds to, and your own body makes the antibodies that then attacks alpha-synuclein. So you could say that the passive approach, it's probably, it's less risky, but you would require frequent infusions of the antibody, as opposed if it's an active, your own body is making the immunization. So some of these we're going to take a look at, and this is this alpha-synuclein again. This is a Lewy body, and this consists of kind of clumped together alpha-synuclein. This is a representation of where we see alpha-synuclein and Lewy bodies in patients with Parkinson's disease, and the brains on the left are going to be what's considered early Parkinson's disease. We usually see alpha-synuclein and Lewy bodies in the brainstem and motor supplementary sorts of pathways. For some folks, the Lewy bodies and the alpha-synuclein spreads to other parts of the brain eventually, and that's when we start to see cognitive difficulty. And then obviously the one on the very right is Parkinson's disease-related dementia. And so you're going to see a lot of Lewy bodies and alpha-synuclein deposited throughout the brain, not just the brainstem. So prasinezumab. This is a multi-center randomized double-blind placebo-controlled study that evaluates the IV prasinezumab versus placebo in patients with early Parkinson's disease who are on stable symptomatic PD medication. This is one I want to highlight especially because we are currently enrolling patients at IU for this study. And it's an exciting study. It's called the PADOVA study. We're looking for patients with a diagnosis of Parkinson's disease between 6 months and 3 years. They can walk unaided. And patients that don't have a diagnosis of dementia. We also would like that these folks, that they're on a fairly stable dose of Parkinson's medication. So, you know, as we're enrolling you, we're not like dramatically increasing or changing around your carbidopa medication. You're on a fairly kind of steady dose, and you have been on a steady dose for a while. So this is the number to call if you know of someone or if you are interested in participating. Our research nurse is Andrea Hurt, and this her phone number down below. I have another, I'll put this screen up at the end as well, that you can write down that number. So prasinezumab, this is an infusion. So this is an example of the passive immunization approach. So this would be, you are given an IV infusion of an antibody that binds to alpha-synuclein. The idea being that once that antibody binds to alpha-synuclein, your body then disposes of the material that it's bound to. It's been through safety trials, and it was shown to be relatively safe. The most frequent observation or side effect was headache, nausea, rash, pruritus, urticaria. This was an infusion reaction, so it happened pretty quickly after the infusion. Usually they were not severe, and they started to reduce in terms of severity over time. So give us a call, let us know. It's exciting. UB312. This is an approach, this would be an active immunization approach. This is currently, this one, I just use this as an example. All of these ones that are discussing are just examples, and there's many different types that are being looked at, but I just decided to kind of use UB312 as an example. This one in particular is being done by a company called Vaccinity. It's not currently enrolling in the United States. It's a phase 1 trial, but it's a 44-week randomized placebo-controlled double-blind single-center phase 1 trial. And they're basically looking at, it's a safety trial, and they're identifying what dose is most appropriate before they move on to larger phase trials. Finally, this one is more, this is a alpha-synuclein blocking approach. So this is, it doesn't use an antibody, but it uses another compound to block the accumulation of alpha-synuclein. This one is it's a phase 2A, and the last time I looked, the closest spot that's enrolling patients are going to be in Chicago, and it was well tolerated in phase 1 trials. Okay, so stick with the alpha-synuclein approach here. We've been talking about sort of number 2 and number 4 in terms of preventing misfolding or blocking the aggregation of alpha-synuclein, which eventually causes a Lewy body, as well as the disposal of aggregated protein. There are approaches that involve potentially reducing the development of alpha-synuclein by using gene silencing therapies, in particular, in this case, using an antisense oligonucleotide. So this is an approach that can target LRRK2. So, and we're going to talk about this one here. So P2B094, it's an antisense oligonucleotide for LRRK2. LRRK2 is our most common form, genetic variant, monogenic form of Parkinson's disease. 30% of people that have LRRK2 end up developing Parkinson's disease. The gene itself encodes for the LRRK2 enzyme, which acts on several different proteins in the cell. The exact mechanism why LRRK2 increases the risk of Parkinson's disease has not really been figured out yet, but there is evidence that LRRK2 does act to regulate and help regulate alpha-synuclein production. But there are some other theories as to why LRRK2 is important in Parkinson's disease as well. So right now, this is a study that's going on. This would be obviously for people only with the LRRK2 mutation. Current sites include Chicago, Michigan, and Ohio. And is currently a phase 1 trial. And for anybody that is interested in knowing more about these trials, I can give you the information. Basically, all these sites that I found were found on clinicaltrials.gov. Okay, moving on. GLP-1. So we're going to talk about, this is something completely different than alpha-synuclein. So we're going in a different direction here. For some time, there have been studies that have shown an association of diabetes and Parkinson's disease, interestingly. GLP-1 agonists are approved for treatment of diabetes. GLP-1 receptors are found in the brain, and they've been shown to play a role in neuroprotection and inflammation. So someone thought, well, if there's an association between diabetes and Parkinson's disease, what happens if we give these compounds to people with Parkinson's disease? So there were some promising animal models, and then there have been some small trials showing some motor benefit after giving exenatide, which is a GLP-1 agonist, to folks. So this concept of inflammation in the brain of Parkinson's disease is quite interesting. So there was a study that was done in 2018 where people who were prescribed 2 different classes of immunosuppressants had lower risks of developing Parkinson's disease. These 2 classes were corticosteroids and then IMDH inhibitors, which were steroid-sparing immunosuppressants like azathioprine. So basically, they found that if people were given these immunosuppressants, they didn't develop Parkinson's disease to the same degree. So then you may ask, well, why aren't we giving immunosuppressants to Parkinson's disease? Well, immunosuppressant medications in general, they tamp down the immune system that fights infection, leaving people who are on these medications more prone to infection. Corticosteroids specifically, they have a whole host of additional side effects, including behavioral changes, bone loss that make them unsuitable for a lot of folks with Parkinson's disease because of the risk of falling. And just because it was shown to be associated with a lower risk of Parkinson's does not mean that there's a causation relationship, okay? So we've now known for a while that smoking has been shown to be associated with reduced risks of Parkinson's disease, but we're not recommending everybody start smoking, okay? There's also an association with inflammation in inflammatory bowel disease. So increased inflammation in the gut may contribute to disease development in Parkinson's disease. So patients with inflammatory bowel disease have an increased risk of Parkinson's disease. And it's been shown that certain genetic variants of the LRRK2 is also a risk factor for inflammatory bowel disease. So an example of this is exenatide. This was a small study that was done after this was given to patients with Parkinson's disease, and essentially the blue line, the red line is like baseline placebo. The blue line is the reduction of the UPDRS motor score, which is how we examine patients with Parkinson's disease, and it showed a slight reduction in the scoring. Again, it's a GLP-1 receptor agonist. It's currently not enrolling in the United States, but it is a phase 3 trial. So this is one theory as to why potentially GLP-1 agonists can reduce inflammation, is because it reduces the activation, it's thought of microglia. So these are important in an inflammatory response in the brain. If you reduce activation of microglia, then you also thereby reduce interleukins and TNF alpha. These are like pro-inflammatory cytokines that can increase the risk of inflammation in the brain. Okay, so GBA. GBA, this is a gene that increases the risk of Parkinson's disease. If you have 2 copies of the GBA, then you get what's called Gaucher's disease. GBA is important in how lysosomes are function in the cell. So this is just like a picture of a cell. We'll call this a neuron. And in the cell, you have a nucleus, which is where your DNA is stored. But then there's these little green globules called lysosomes. Lysosomes are the garbage disposal system of the cell. And so GBA mutations affect how well lysosomes function. Again, if you have 2 copies of a mutation of GBA, then it causes Gaucher's disease. This is basically what happens is this like gunk in the cell just builds up. It kind of takes over the cell itself and prevents it from functioning well. If you have 1 abnormal gene, then it increases your risk for Parkinson's disease. So one of these medications, Broxol, has been approved in Europe, and it's been shown to improve function of GBA in neurons. And so there is a trial going on right now in Norway for dementia with Lewy bodies. Again, this is a disease that also involves alpha-synuclein and Lewy bodies, but and this is something that they're eventually going to do some large-scale placebo-controlled trials. Okay, and then finally, GDNF. So GDNF is a neurotrophic factor. This is like a growth factor for neurons, and so someone had the idea of injecting this directly into the brain. So the strategy of infusion of GDNF into the brain, it's been studied a number of clinical trials since the early 2000s. The most recent study was published in 2019 and presented the results of that trial. So they surgically implanted GDNF through this delivery system into the brains of 35 people with Parkinson's disease. The other folks, this was a placebo-controlled trial. So the patients that were in the placebo arm, they underwent all the steps of the infusion, but they were not given the medication itself. So the 2 groups were compared, and these were published in the journal Brain. So there was a trend toward improvement in the treatment group as compared to the placebo group when evaluated off of medication, but the trend was not statistically significant. So at first it was kind of a dud trial. However, after kind of reviewing the data, they found that 9 patients of the 35 who received the treatment, there was a statistically significant improvement in their symptoms. So it's been known that there's many different forms of Parkinson's disease that exist, and I'm sure all of you are aware of this, either having friends or family, or you go to a Parkinson's disease class, you can see people that are in different stages. Some people look really different than others. Some people respond to medications very differently. And so what's potentially exciting about this study is, we've been doing research trials on patients with Parkinson's disease, and maybe we've been lumping everybody into the same group of patients when in fact we should be kind of dividing each subgroup out, because we might be able to see that maybe for some of these patients in some categories you get benefit and for others you don't. So for this study, they found that 9 folks getting GDNF directly injected into their basal ganglia showed improvement. And so these were examples of some of the people that did show improvement. The bottom, basically the baseline GDNF, you can tell, you kind of have to hallucinate a little bit here, but at the bottom, the 2 brains at the bottom, the one on the right, it's a little bit more active and a little bit bigger compared to the one on the left. And so the idea is that the dopamine producing cells of the brain were actually triggered and were grown as a response to the GDNF injection. These are some other therapies that I didn't get to, but that are also being looked at. I won't kind of go into these, but there are many other strategies that people are kind of looking at. And then finally, again, this is the passive immunization approach that we are doing here at IU. And again, we're looking for patients with a diagnosis of Parkinson's disease between 6 months and 3 years, that you can walk unaided, you don't have a diagnosis of dementia. This is an IV infusion. And for patients that have questions about this or want to know more information about this to decide whether or not this is right for you, please give Andrea Hurt a phone call, 317-963-7449. And we are currently enrolling actively right now. We're looking for probably a total of five patients total. So let us know if you are interested. These are some of my sources. Thank you, everyone.
All right, thank you so much. We really appreciate your presentation, Dr. James. I know a lot of people are always so interested in medication updates, so we appreciate it. Thank you for that informative presentation. And now, guys, we are super happy to announce our next presenter, Maggie Girard. Maggie is a registered board-certified art therapist and licensed mental health counselor in Indiana. She holds a master's in art therapy from Drexel University in Philadelphia and serves as director of art therapy outreach at IUNC. She enjoys working with patients in neurology and also sees patients at Life Care, IUH's HIV clinic, as well as kids and teens in a small private practice. Thank you so much for joining us today, Maggie.
Thank you. All right, I'm excited to be here. Let me share my screen. Sorry, this isn't working the way.
No, it's okay.
Okay.
Take your time. It's the virtual world, right? So we've all gotten used to it.
Yes.
And Maggie, if it was pulled up on your desktop at first, just make sure it was pulled up first before you do the share screen.
Yes, it is pulled up, but it's saying to open system preferences, which hadn't happened before. I apologize.
No worries.
Mm,
I could also share on my end too, if you want to just say next. So
Okay,
So-
maybe we should do that. I apologize.
no worries. Just give me one moment here.
Thank you.
You're welcome. Just give me a moment to do this. And just say next when you want me to go to the next slide.
Okay, thank you. So today we'll talk about the benefit of art therapy, and specifically for folks with Parkinson's and their loved ones. Next. And I have no disclosures to report. Next. So think of art therapy. It might be familiar to you, it might not, but art therapy is essentially psychotherapy with art making integrated into it. So it isn't unusual for someone to think of art therapy as something that's mostly for kids. And I think that's because so many of us stop making art as we leave childhood. But as I'll share today, art therapy offers many benefits for people living with PD, as well as for their care partners and their loved ones. There are just so many parts of the human experience that don't fit easily into words. And art can act as a bridge. It can help us access these deep parts of being human, and it can improve our quality of life as we do so. Next. So I'll tell you a little bit about what art therapy is in case you aren't familiar. It's an integrative mental health and human services profession that enriches the lives of individuals, families, and communities through active art making, creative process, applied psychological theory, and human experience within a psychotherapeutic relationship. So today I want to focus a bit on that last part, the human experience within a psychotherapeutic relationship, because you might have been to like Michael's or Barnes and Nobles or Target and you've seen coloring books labeled art therapy. And that is all good and well, but that's a little different than what we're doing today. So I'll kind of talk about the differences within. And I guess I would say that both are valuable, both art therapy with an art therapist and art making on your own, where you might find it soothing and therapeutic to color, or maybe you're a knitter, or you like painting, or even rolling and sculpting Play-Doh with your grandkids. All of those are wonderful and are ways that art can be therapeutic. But the experience of creating artwork with an art therapist can feel this way too. And then there's the added component of reflection and support. And that can help us put words to our experiences that, like I said earlier, are just sometimes difficult to put into words. And this can give us a sense of owning our own stories in a way that can be really empowering. Making art activates many parts of the brain and can be fun and relaxing. Next. So I'll share briefly about the educational requirements for an art therapist, because again, the term art therapy sometimes gets thrown around and it's hard to know kind of what is what. So art therapy is a master's level mental health profession. So if you are seeking an art therapist, you want to make sure that they have specifically a master's degree in art therapy. And within those programs, they'll be required to have 100 hours of supervised practicum and then 600 hours of supervised art therapy clinical internship. So an art therapist will get quite a few hours hands-on prior to graduation. And then once somebody does graduate, they can work towards their ATR, where they're a registered art therapist, which they kindly call ATR instead of calling us a rat, or be a little cheesy maybe to be called art after your name. So an art therapist registered or registered art therapist. So we work to get a minimum of 1,000 post-education direct clinical hours and do that supervised, and then you can sit for a board exam. And many art therapists will also seek state licensure because many states don't recognize these credentials yet in a way that you can bill insurance. So you might see more letters after somebody's name, and that might be for their state licensure of some sort. So next. And I meant to say before too that we now have 3 master's programs in art therapy in Indiana. So it's a field that's really growing within our state, which is exciting. So there's 2 programs here in Indianapolis and another one, St. Mary of the Woods. It's closer to Terre Haute. So that's pretty exciting for art therapy. I wanted to touch on the expressive therapies continuum here. And that is a theoretical model for art-based assessments and applications. This is some of the theory that guides our thinking as we decide what we'll do in a session. It helps us determine what type of media would be appropriate. And there are 3 levels on it you can see here. So across the top, you can see cognitive and symbolic. And in the middle, you can see perceptual and affective. And then at the bottom, kinesthetic and sensory. And the 3 levels appear to reflect different functions and structures in the brain that process visual and affective information. So assessment with the formal elements in a piece of artwork can help a therapist to determine how the client is processing information with each of the different levels. So then we can tailor our treatment based upon this assessment. For Parkinson's, there have been some really exciting studies the last few years that indicate that clay is especially beneficial for people with Parkinson's. Clay is often used when you're working in the kinesthetic and sensory levels, although it can be used in other levels too. You can obviously create something more symbolic out of clay, or it can fit anywhere in the ETC, but as you see the picture of clay down in the sensory part, is especially wonderful for activating the sensory parts of our brain. And I love handing people a piece of clay and just watching them relax. Especially Crayola has one kind called Model Magic that is really clean, so it doesn't make your hands really messy, like, you know, maybe the kind of clay you used in elementary school, or you might if you're a potter. And it just is a very soothing, relaxing thing to do, to squish a lump of clay. So in therapy, we sometimes use this to help relax and soothe somebody. That can also address emotional stress and trauma brought on by a Parkinson's diagnosis or by the disease progression that they're experiencing. And with that emotional expression, they're able to better tell their story. And once you can tell your story and put words to it, you have some control and ownership over it. And it doesn't feel quite as scary as something that's more nebulous that you haven't been able to put into words yet. When we experience trauma, that tends to impede our expression. So until you're able to make sense of your trauma and put some words to it, it has power over you. And art therapy is one way that we often see people are able to invite and allow those emotions that they've experienced. And once these emotions emerge and they can be named and shared, there's more power and ownership there. The manipulation of clay can also help with motor symptoms. It can be really helpful to tremors or that kind of pill rolling movement that people might do with their hands with Parkinson's. So it can be handing somebody a piece of clay to hold, or a piece of Model Magic can give them something different to do with that energy in their hands. All right, next. So I was just mentioning how it can affect some of these motor symptoms. And I was surprised initially to learn that art therapy would affect them, but now I've had the privilege of seeing it firsthand. And it can improve one's dexterity. It can decrease temporarily your tremors. It can help with freezing. And there have also been some exciting studies around visuospatial perception, or how we're able to see like contrast sensitivity with abnormal light and dark adaptation, or color discrimination, with irregular eye movements or impaired motor perception, reduced visual recognition, and altered perception of extrapersonal space. When someone has difficulty perceiving the world around them, it's easier to fall or easier to have balance challenges. And the decrease in one's visuospatial perception, can affect activities of daily living, like reading and walking independently, driving, maintaining overall fitness, physical fitness. And I know those are important to most people. So the way that art making can potentially affect our visual problems with Parkinson's is pretty exciting. And people with Parkinson's tend to have some types of visual problems at all stages, I believe, of Parkinson's. So that research is exciting and hopefully something that can be used to help more people with Parkinson's. Next. There's also the non-motor symptoms that art therapy benefits that are more along the lines of what people associate with most types of psychological therapy. So, art therapy can help with your self-confidence. It can promote neuroplasticity. It can aid in concentration. It can help us with our sense of self. Like I was speaking to earlier, just being able to know our own stories and own them can be really helpful. It can help with our cognitive processes, our social interactions, which is important within Parkinson's too, as our communication is affected. It can reduce stress, which is huge, both for people with Parkinson's and also their loved ones and care partners as they navigate this together. It can improve somebody's mood, and it activates both sides and different parts of the brain, which is all really exciting. Next. Art therapy can help with neuroplasticity, which is how the neural networks of the brain can change through growth and reorganization. It can take forms of changing habits or thinking about something differently, and as mentioned before, can target both motor skills and cognition. Next. So art therapy, so the neural mechanisms in art making can enhance both the visuospatial functions for people with PD, as we mentioned earlier. So this is one of those studies that was pretty exciting. Next. So 45 minutes of art making can be shown to significantly reduce cortisol levels, which is exciting. So that's one of the ways we can measure stress before and after a session. And most people who enjoy making art know this, of course, that you walk in and sit down to start creating, and when you finish and stand up, you feel better. And the study that showed this was able to measure cortisol levels through saliva, and could see this happening in real time, which is pretty cool. I think there have also been studies using QEEGs that have found that multiple parts of the brain are activated during art making, and that the brain activity immediately following an art making session differs significantly from the brain prior. And I've observed time and time again how patients leave an art therapy session calmer, and it seems like they've been able to experience some integration during that time making art. Next. So some things that may or may not surprise you is that even viewing artwork benefits your brain. You could scope out some galleries in your community or visit an art museum. And in doing so, you would be activating the dopamine reward centers and areas of the cortex associated with positive affect. So that'd be something to pay attention to if, after you view art next time, if it changes your mood and affect and what that's like for you. Or maybe there's a piece of artwork in your home that you could go admire today and just see what that's like.
Hi, Maggie. Just wanted to quickly mention, we can hear some papers rustling in the background. Sorry, if maybe just try to keep it away from your keyboard. Thank you.
Thank you. Yes. All right. Let's see next. So with art therapy, there are really no limitations. Something I didn't mention earlier that I should have is that there's absolutely no talent, no previous art experience that's necessary for art therapy. A lot of times people will shy away from participating because they think I'm not an artist, or last time I made art, I was in 6th grade. That's not for me, but I'd really urge you to give it a try, especially with the benefits that we found, because there's not much to lose. And with changes in dopamine that occur during Parkinson's and with the medications, you might find that you like it now in a way that you didn't before. And even if you aren't able to make something that you think is beautiful, it's still a way of communicating. And that communication can be really effective and really helpful. Art therapy is really about more the process of creating art, less than creating a beautiful finished product, which is different from most of our memories of art class in school where we're getting a grade. Your art therapist, I promise, is not going to grade you. They don't care if it's pretty, if it's scribbled or a stick figure. That's all well and good. It is about communicating, and there's really something life affirming about putting a line on a piece of blank paper. It can be scary to do that, even if you know the consequences aren't much. So it's really worth the try. And there are infinite ways to make and appreciate art, even without traditional art supplies. So you'll see in this picture, one of our art therapists, Barbara, made this with, or her patient made this via telehealth during the pandemic when we were still navigating how to get art supplies sent out to people. And I think it's just stunning. They took some lemons from their kitchen and went out for a walk and collected some art supply or some art supplies, some nature. And they were able to make this mandala to help express what was going on with them right then. So it really is limitless and easier if you have art supplies, but you can do a lot without too. The junk drawer in your kitchen probably has some things you could use to make a mandala. Next. So I wanted to share what we did with some of our programming in the last year. Our IU Neuroscience Center was lucky enough to be a participant in one of the grants from the Parkinson's Foundation, and we named our program Find Your Groove. And we were able to offer a choir, dance movement therapy, and several art programs to participants at no cost to them. And I was lucky to get to help facilitate the art portion of this. So we had an art techniques group where we met for 12 weeks. All of this was over Zoom. And during those 12 weeks, we taught different types of art making, and each person had a packet with different art materials that they could use at home. And we created art together and shared what we worked on. And the image you see here is from our mural project. So that was the second portion of the art that we did. And the mural was created over 12 weeks, also by Zoom. We sent out materials to each of the participants, and each person made a column. So from top to bottom is created by a different artist. And we explored some art history through that time. So you'll see some of them resemble pointillism, where we are practicing making little dots. Some of them look more like a Rothko, where they're kind of blocks of color. And we did some impressionism. So there's some different art movements integrated into this. But each column is created by a separate artist and then was either mailed to me or collected at the Neuroscience Center so that we could assemble it. And it's all painted in acrylics. And it was just really such a joy to meet each week and paint together. And it was really exciting as I got to collect the pieces and got to see the full image emerge. I didn't anticipate it would fit together as well as it does. So that was pretty exciting to see just how I thought we would probably have to put some space between each of the pieces so that it would kind of imply that all the pieces would fit together, but they really came together quite beautifully, and it has such an energy to it. I hope that maybe you'll be able to visit it in the waiting room in the lobby of the 3rd floor in neurology if you haven't already. It was also a safe space where participants could just chat and could share about their experiences living with Parkinson's, like what was helping them this week, what was challenging for them this week. And they were also able to share at times about which painting styles decreased tremors or increased tremors. For some people, pointillism was really not helpful. For others, it was. One participant found painting with their fingers was really helpful for tremors and finished their beautiful pieces that way. It was really incredible to see participants who had more progressed Parkinson's, like for whom speaking in group was really a challenge and walking was a challenge, were still able to paint incredible additions to this mural. So it's really moving to see it all come together. You can also hunt down the Parkinson's tulip in it. There's an official Parkinson's, a couple official Parkinson's tulips hiding in there that are crimson that have white around the edge. So that's kind of fun. And Parkinson's, if you don't know, tulips are a symbol of Parkinson's, which is why we chose tulips. I think the next slide has a picture of it in the lobby. Yeah, there it is. So we're working on getting a plaque for it, but next time you're coming in for an appointment, if you're at IU, you can come see it, or if you're in the neighborhood, you can swing by and check it out. It's on the 3rd floor in the neurology lobby. Next. So to find an art therapist near you, you can reach out to the Parkinson's Foundation helpline, which is a great resource. And the American Art Therapy Association also has an art therapist locator that you could use to find. And Psychology Today can also be a resource, but that does tend to be a place where I think art therapy is a box you can click on there. So you may run into more people who don't actually have an art therapy background, but might use artwork sometimes in their therapy practice. So that's just something to be aware of. Next. And there's my contact information if you are a patient at Indiana University and you would like to connect with our program. So we provide, there are 3 of us right now who are in the clinic part-time, and we provide art therapy with individual, we can do couples or family art therapy, and we're able to see people with Parkinson's, but also their loved ones. So if you're a care partner, or maybe you have a parent with Alzheimer's or with Parkinson's or Alzheimer's, we're able to see you and just help you process this time. And our goal is to help people with quality of life and just to help you kind of make sense of this and own your story and live as well as you can. You can email us or call our clinic, and we'd be glad to connect you as best we can to services. We're trying to start some groups this summer. That would be probably like a 4 to 6 week group that for people with Parkinson's and also for care partners. So if you fall in either of those roles and you are an IU patient, we'd love for you to reach out. there's no cost to participate. And I think that's all I have. Thank you very much.
Thank you so much, Maggie. We really appreciate it. And I love seeing those tulips. I've not seen them before and it's beautiful. You're right. It's like it was meant to be. So, so thank you so much for your time, Maggie, and we will see you at the Q&A at the end. So everyone, we are going to take a 5-minute break. So during this break, you can get up and stretch, go get a glass of water if you need to. And during this time, we will highlight some local Indiana resources and also the research opportunity that Dr. James spoke about earlier. But don't worry if you miss them, if you step away, because they will also be included in the follow-up email. See you soon. Hi, everyone. Welcome back. Just give everyone a second to come back here. So we're really excited for our next presenters. We have Hilary Nuest, Nina Shahin, and Ryan Neyenhaus. So I'll read the bios of all three of these individuals, and then Hilary will be starting the presentation. So Hilary Nuest received her doctorate at Indiana University and has worked at IU Health in various care settings. She is passionate about evidence-based practice in the neurological patient population and received her neurological clinical specialist certification in 2021. Hilary strives to improve care for patients with Parkinson's disease through best practices, interprofessional collaboration, and colleague training. Nina Shahin has over 20 years of experience as a medical speech language pathologist in acute care, outpatient acute rehab, and private practice, treating complex neurological conditions. She received her graduate degree from the University of Wisconsin-Madison and holds multiple advanced certifications in speech and swallowing treatments. Nina is passionate about working with clients who have Parkinson's disease and optimizing outcomes through individualized treatment plans supported by the most current evidence-based research. Ryan Neyenhaus received his master's in occupational therapy from the University of Indianapolis. Ryan has over 19 years of experience in acute care and outpatient settings, working with client populations with various neurological conditions. Ryan is passionate about working with his clients and developing a strong multidisciplinary collaboration. Ryan greatly enjoys working with persons with Parkinson's disease and actively participates in continued professional development to maximize patient outcomes through his best practices. Hilary will be presenting first, like I said, so we welcome you, Hilary.
Hi, everyone. I'm going to share my slides. All right. Are you guys able to see that?
Yes, we can.
Okay. All right, so we'll be exploring the role of rehab professionals in Parkinson's disease. What is neurorehabilitation? Well, or neurological rehabilitation can be defined as a physician prescribed program designed for people with diseases, trauma, or disorders of the nervous system. It usually consists of a team of physical therapists, occupational therapists, speech language pathologists, and maybe a biomechanist. Praxis states that neurorehabilitation is arguably most important for the treatment of axial symptoms such as freezing, hypophonia, dysphagia, postural instability, and postural disturbances that respond poorly to drug therapy. There's lots of ongoing research examining the benefits of exercise and therapy on the motor symptoms of Parkinson's disease. One thing I hope you'll take away from this presentation is that regular intensive exercise and activity is very important, but it does not replace therapy. Instead, they're complementary to each other. We often talk with our patients about the dental model for therapy. We go to the dentist to prevent cavities. That's how we want you to view therapy, to help stop or slow the progression of motor symptoms with lots of education and lots of training. This always includes resources and a plan for how to exercise once therapy is complete. Neurorehabilitation often combines traditional therapy techniques with emerging advanced technology in order to maximize the effectiveness of treatments. When you're looking for a therapist or a neurorehab center, you should try to find a center with therapists who have advanced training. Look for neurological clinical specialists, LSVT certified specialists, and Power Move certified specialists. You could also reach out to your movement disorder physician to assist you. These certifications help inform you that the therapist is invested in evidence-based treatment and has the experience and knowledge to effectively treat the specific issues presenting in Parkinson's disease. If you've never been to physical therapy, occupational, or speech therapy before, the first session will always be an evaluation to assess where you are right now in terms of mobility, balance, communication, cognition, swallowing, and daily functional activities. We discuss and create goals for your therapy based on what's important to you. Then we'll create a treatment plan customized for you. In physical therapy, this may include strengthening, balance retraining, gait training, postural reeducation, or safety and fall prevention training or education. And when should you seek out a physical therapist? Now. So we always recommend kind of at diagnosis to ask your doctor about physical therapy, occupational therapy, and speech therapy. However, if you're hesitant or just not ready right now, things that would be important to seek out help for include, or if you notice changes in your balance, falls or tripping, changes in your ability to stand up from a chair, freezing, difficulty walking, if you feel the need for education or care partner training, if you're having weakness or back pain. One of the treatments we may do in physical therapy is gait training to help improve your walking ability, safety, and efficiency. Every treatment is customized to your individual needs. Parallel bars seen in the picture are commonly used in treatments. They can provide stability to help you feel more secure while we challenge your balance or gait. You may use body weight support systems to do this with or without robotic assist, which we'll show a little bit later. Another treatment we may do is for your balance. This is a very common treatment for people who have Parkinson's because of the motor symptoms that can be associated with it. Like I mentioned before, postural instability, freezing, and dyskinesias. We can help prevent falls by working on strengthening, reducing freezing episodes, practice and repetition, and addressing your posture. We can safely and effectively treat balance deficits using traditional techniques and advanced technology. You can see this man in the picture wearing a harness. This allowed him to feel more secure and provide a safe environment for the therapist to really challenge him. All right, and we may assess your walking with video and pressure mapping to help analyze and treat your specific issues. This was taken on this patient's first day of therapy. I'm going to start this. So you can see she's walking with a walker. She's pretty slow. It's kind of a forward lean and leaning to one side. Okay, and then after a few months of therapy, she made quite a bit of progress and was even able to get to start walking without her walker some. You can see, she's standing up taller. She is taking bigger steps. She's getting some arm swing. Did have her use a postural kind of support brace to help as well. LSVT is another treatment approach we use for Parkinson's disease. And I mentioned before, it's something to look for when searching for a therapist. This protocol is designed for people who have been diagnosed with Parkinson's disease and includes intensive therapy 4 days per week for at least 4 weeks. It takes a lot of hard work and commitment, but the results can be great. Their mission is to empower people with Parkinson's to restore and maintain their highest levels of functional communication, mobility, and independence in daily life through scientifically supported therapy programs. And the two you'll see are LSVT Loud and LSVT Big. Nina will talk a bit about LSVT Loud. Like I mentioned earlier, exercise alone does not replace therapy. Why? Well, not all types of exercise focus on amplitude. Amplitude-focused exercise is needed every day due to small and slow movements, which affect everything a person with Parkinson's disease does. Not all exercise focuses on sensory awareness challenges. When a person with Parkinson's disease uses movement that is normal in size, it can feel too big to themselves. Unless they are specifically trained and what we call recalibrated, their movements will become smaller over time. Also, not all community-based exercise is personalized to you. And functional task practice in LSVT Big is important for long-term carryover. Okay, and I want to show you a video. It shows treatment with the patients walking kind of before and after they completed their therapy course. So on the left, you can see this man. He's taking pretty short, small steps that are pretty typical with Parkinson's. And he's using a cane. And on the right, he was able to walk without his cane. And you can see he's got some nice arm swing. He's taking bigger steps. Just looks more confident, and he's able to go further. All right, now now Nina's gonna delve more into speech therapy's role.
Hello, everybody. So I'm going to talk about the speech pathologist's role in treating Parkinson's. So speech pathologists treat swallowing, cognition, language, and voice. And we also collaborate with our other rehab professionals to optimize outcomes. So we're going to talk about the changes that can occur in swallowing, and this can occur at any stage of Parkinson's disease. These changes can affect the oral, pharyngeal, or esophageal phase of the swallow. These abnormalities could include discoordination, residue of food or liquid in the mouth and throat, leakage of food or liquid into the airway, reflux, and esophageal motility disorders. Swallowing abnormalities can affect quality of life and safety. There was a recent study that showed that 25% of patients with Parkinson's suffer from aspiration, which involves foreign material entering the airway when you eat or drink. So it's especially important to identify swallowing abnormalities and treat them effectively. Signs or symptoms of swallowing disorder could include coughing or choking when you're eating or drinking before, after, and during a meal, the feeling of food sticking in your throat, weight loss, drooling, or just a fear of choking. If you're experiencing swallowing difficulty, your speech pathologist will likely refer you for a modified barium swallow study. This allows us to visualize the anatomy and physiology of the swallow and determine an individualized treatment plan. We will use evidence-based exercises that may include tongue strengthening, pharyngeal muscle strengthening, and respiratory muscle training to strengthen the volitional cough response. We might make suggestions for dietary modifications and swallowing strategies. Note that there are behavioral interventions to manage drooling, and also understand that good oral care and regular dental cleanings are extremely important for overall health. If you are experiencing constipation, also speak to your doctor, as this can worsen reflux. We're going to now speak about cognitive and communication changes. So there is a change in cognition with normal aging, in addition to changes that can occur as a result of Parkinson's disease. These can include difficulty with concentration, multitasking, memory, word finding, and processing speed. However, there's much speech pathologists can do to treat cognitive disorders. So speech pathologists educate clients in brain health practices, and we can also complete cognitive drill training during weekly therapy sessions that I like to call brain boot camp. I also wanted to briefly review some brain health practices. These include social engagement, managing stress and depression, exercise, sleep, healthy eating, and cognitive stimulation. We know that learning a new skill is especially cognitively stimulating, so I always tell clients, pick up a hobby that you've always wanted to try. Remember that our brains are highly plastic and remain so throughout our life, and the aging brain is capable of learning. We've all heard the saying, use it or lose it. Inactivity, whether physical or cognitive, accelerates deficits. So early and ongoing intervention is the goal of therapy in order to minimize impact on health and maintain a high quality of life. So there can be speech and voice changes, and these may be changes in breath support and respiratory strength, changes in the vocal cords that cause a breathy, hoarse vocal quality, reduced volume, fast rate, reduced pitch range, and imprecise articulation. And also rigidity in the mouth and face may decrease the ability to convey emotions and humor. Speech pathologists work closely with ear, nose, and throat physicians. If appropriate, they will complete a full assessment of your voice, including viewing of your vocal cords to determine best treatment options. We will incorporate their findings into your individualized treatment plan. We use the Lee Silverman voice treatment, and this is a research-based intensive speech therapy program completed 4 times a week for 4 weeks that directly strengthens the muscles used to produce speech and voice. And I'm going to play a clip of a patient pre and post voice therapy.
Have you noticed any changes in your speech or your voice that you would associate with Parkinson's?
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Uh-huh. Anything else?
I stutter, which I never did before.
Do this for me if you would. Take a deep breath and say ah for as long as you can.
Ah.
Good for you. Okay. Would you say Parkinson's disease has caused you to talk less?
Yes,
Because?
because I stutter and then I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention to it because they can't hear me. Till I get mad and then yell.
Take a deep breath and say ah for as long as you can. Have you noticed changes in your speech or your voice as a result of the speech therapy?
Oh, yes.
What have you noticed?
I talk louder. I think louder. I'm going to sing with the Sons of the Pioneers one of these days with my voice.
Good for you. That's excellent.
So you can see the difference, obviously, pre and post therapy and what impact it makes on her communication and quality of life. The next thing I'm going to talk about is another tool that could be recommended. This is called the Speech Vive, and it's a wearable device that triggers the brain to encourage the patient to speak louder and slower. So this can be used as an alternative to traditional therapy. We also incorporate inspiratory and expiratory muscle training. So we train persons with Parkinson's to use pressure threshold devices to retrain the respiratory muscles. Research has found that respiratory training assists with speech breathing in addition to swallowing and general exercise endurance. And now Ryan's going to talk a little bit about the role of occupational therapy in treating patients with Parkinson's.
Ready? Thank you, everyone. So yes, going forward, when we're talking about just life changes and everything, one of the things we want to look at is we also want to incorporate family and our caregivers into every aspect of our life as well. And that can go as far as from transfer training, looking at your current home situation, how can we assess your home, make that as safe for you so you can remain as independent as long as possible. Also looking at community resources. And the big thing is always fall prevention. We want safety, 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 but we also want to understand the individual and make sure that they continue to have that independence throughout their life. So one of the things looking at home safety, obviously, is accessibility in and around the home. And all of us can figure out all those barriers that come into our home, especially getting in and out of the bathroom, those tight spaces. Some of us may be using assisted devices, and some of us may not be using assisted devices to help us keep us safe. So one of those things may be looking at specific ways that our home can be modified. And one of it could be advanced technologies. Some of us may have different devices that we can say into our phone or in our house to access certain aspects like turning on lights, but also making voice assisted calls, but also only even fall monitors as well. Going forward, obviously, too, it's not just about the home, but it's how we go about caring about every aspect of our day as an individual, from the time we wake up in the morning till the time we go to bed at night. And that may be looking at how we can access writing, using the adaptive utensils for cutting up our food, holding onto our food, adaptive clothing in itself, from just adaptive snaps, adaptive devices to make ourselves pull up our zippers, but also just maximizing our independence. And even when it comes to our hobbies, sometimes we forget about hobbies. Hobbies are very important for us as individuals. And we sometimes lose that when we sometimes lose our ability to function. So that is the role of therapy, is really to help find those strategies along the way and be as creative as we can. Obviously, looking at our safeties, and sometimes this is very hard, but sometimes we may need a walker to safely get from point A to point B, a cane as well. But even as far as looking at a wheelchair, from just a standard like transport chair that help us getting to and from the hospital or in and out of our doctor's appointments, or even going to an airport that long way to the plane. But also getting up and safely getting up off and down from different services. We may recommend a gait belt, one, not only to help you stand safer, but also for family members to help you stand safer, because if they're assisting you and if they get hurt, obviously then we know it's going to be a big challenge for both you and your family. So again, going forward, we look at collaboration between OT, PT, and speech. But obviously, when we're talking about assistive devices, we also include you, the individual. And so we may be looking at different types of walkers, anywhere from just like, as we've all seen, various models and shapes, but like a rollator. One, why we like rollators is because there's a built-in seat. So if you're tired, you can sit. But obviously, there's ways to carry things, because when our balance is not great and we're trying to carry things with our hands, or we have tremors with our hands, that increases our risk for dropping items, therefore increasing our risk for falls. Sometimes with our mobility, we're not able to keep a good step length. And so different style walkers allow us to provide not only a visual, but an audio cue, and obviously some proprioception, because they're heavier to help you keep your balance safe when you're moving. Obviously, again, looking at the other individuals, we're looking at adaptive aids. Some examples that you see here are zipper pulls, just to help get those little pesky little zippers on our jeans or our jackets. This makes it a little bit easier, so we're not messing around with trying to fill those clothings and get them a set, or having a family member help us. But again, going back to the bathroom, we may be looking at adaptive equipment. One easy way is looking at just adding a seat to the tub or shower. So one, we're not having to come up and down from a lower surface, or it gives us the safest place to sit, because when we're in the tub or the shower, the water's wet, the ground's slippery, and then therefore we could fall as well and have an injury. And again, going forward, looking at utensils for eating. Again, this is something that you would be having an assessment and an ongoing conversation with your therapist, because we don't want to make it sound like it's coming from us giving you these ideas, but more of a team effort between you, collaborating with you and your daily routine. I want to talk a little bit, you've seen this slide previously from Hilary, but again, speaking more specifically to us here at IU Health, and locally here in the Indianapolis area, but within the IU Health system. Again, we want to have a multidisciplinary and interdisciplinary team approach between physical therapies, occupational speech therapy, and biomechanists as able. But we want to look at also maybe technology. Some facilities are blessed to have different ways of approaching, accomplishing the same end goal, which is independence. And so using emerging technologies and ongoing research to help maximize the effectiveness of the treatments and also carry over within daily life. So with that in the expertise, we want expertise that's focused on neurological conditions across the lifespan, from early onset to late stage and anywhere in between. And obviously that is where that ongoing assessment. So we want to make sure that it's not just we see somebody for a short period of time, but we want to make sure it's an ongoing life approach. Obviously here at IU Health, one thing is we have 7 certified brain injury specialists. We also have board certified in neurology, and obviously LSVT big and loud, which we had previously mentioned. And we're glad to be partnered with the Parkinson Foundation Center of Excellence. Again, it's all about individualizing assessment and treatment specifically for your needs. So obviously, we talked earlier about balance and maintaining balance. So balance training is one of those key components. And so the creativity, not only with the therapist, but obviously the input that you provide with the therapist, how can we make you maximize your goals? Say you enjoy going hiking. Well, hiking has a lot of various terrain. Just walking around your home with little kids and toys all around, we have to be able to change our environment. And I believe we have a video. There we go. Thank you. And so this individual here is just training how you could use a body weight support system or just a harness system to help keep that patient safe, more hands off, but allowing that patient to really be challenged in life scenarios. Again, it comes down to the creativity of the therapist. Oh, there we go. And again, this is kind of a standing assistance, and again, using advanced technology where the body weight support system can minimize the patient's weight, but obviously allow them to walk and support their balance if they're unsteady. But obviously this device can be set up so they can challenge themselves in the event of a fall. They can learn how to correct their balance. And again, balance retraining, as you know, is a big key when it comes to Parkinson's disease and mobility and safety. So challenge that patient throughout their therapy, even if it's not traditional or non-conventional to that individual, but it's again, making their body think outside the box and really challenge themselves in a safe, controlled environment and a fun and challenging and rewarding way with a therapist. Again, going on with advanced technologies, we understand that not every clinic has these types of devices available, but we also know that they may be available in other devices in your area, or if you're looking at providing therapy and for yourself, talking with your care provider saying, I'm interested in therapy, I've done some research, these are some things that are out there. So one of the things is this picture here is called the GEO. It's a robotic assisted walking device. It's used in some clinics, like I had said earlier. But one of the things is it's used for not only just research, but it's also looking at the effectiveness of your type of gait compared to maybe non-traditional overground walking. Obviously, this is where you would want to reach out specifically with your care provider or in your local area to see what specific therapy programs are available to help you maximize your goals. Obviously, one thing that's probably over-mentioned, but it gets overlooked a lot of times is we need to be aware of vision. And, you know, a lot of times we talk about with patients, we say head up, sit up tall, look straight ahead. But with Parkinson's, sometimes we walk with our head down, looking at our feet, but we're not aware of our surroundings. And when we start losing that ability to have that downward gaze and to scan our environment, that obviously creates that higher risk for falls or injury. And so vision training is mostly looking at how we can coordinate head movement, eye movement, along with body movement. Again, with occupational therapy or therapy in general, we have to think about fine motor control, gross motor control of our arms, because we use our arms for bathing, dressing, accessing our environment as well, from a tabletop to computer access, as some of us are still probably working, some of us are retired, and some of us have great hobbies that we really enjoy doing. And how do we maximize that enjoyment in our lives if we start having difficulty with our hands? And one of the things is working with your occupational therapist, particularly, is finding out, well, I enjoy knitting, or I enjoy writing, or I enjoy playing a musical instrument. finding ways to keep that high repetition and that creativity going. Some of it may looking at exploring adaptive ways to hold your devices, or maybe looking at adaptive knitting needles. There's a lot of creative things out there that you can work with specifically with your therapist. Obviously, looking at robotic therapy or balance therapy is more or less to help with the therapist to assess your overall movement. Again, research-based, looking at how we can maximize your independence. Again, these are tools to help guide the therapist to provide a high quality creative treatment. Again, it comes back down to making a plan. You want to consider starting with therapy first. Why? Because PD is complex, as you really know. And sometimes your symptoms and everything may be subtle, but it's enough that it's impacting your independence. And so early treatment is key. Having that early ongoing conversation with your physician and getting set up maybe just for an initial consultation with an occupational physical therapist or speech therapist will really allow us to help kind of fine tune where you currently are, what are your current strengths, and what are you struggling with? Because the goal is to maintain that independence. So again, we want to optimize your function. We want to teach you exactly what to do after each treatment. We want to give you homework. Yes, homework. I know we love to hear that. Home exercise programs. But again, we want to make sure that's individualized for you and not just handing you photocopies. We want it to be a live, ongoing session between you and your therapist. Again, we want to have that collaboration because we want to teach you to move safely and independently. And so some of the things we have you do may seem a little non-conventional, a little crazy at times. But again, our goal is observing what you're doing, teaching you how to move as big as you can, maximize your independence throughout your daily activities, your recreational activities, and again, is to make a plan to keep you moving well through the years. Thank you.
Thank you so much.
Yeah, sorry, we're
To
done.
the three of you. I love it. Thank you so much to the three of you for that really great informative presentation and very practical things that this community can take away. So we really appreciate it. And then we will see you at the Q&A in a little while.
Great, thanks.
All right, now it's my pleasure to introduce our final presenters, Dr. Dylan Seitz and Dr. Angelina Polsinelli. Dr. Angelina Polsinelli is a clinical neuropsychologist and assistant professor of neurology at the Indiana University School of Medicine. She has clinical and research interests in neurodegenerative diseases of aging, including Parkinson's disease. Dr. Dylan Seitz is a clinical neuropsychology fellow at the Indiana University School of Medicine. His clinical interests include cognitive aging, dementia, movement disorders, such as Parkinson's disease, and caregiver burden. Welcome to the both of you, and the floor is yours, Dr. Polsinelli.
Thank you so much. All right, here we go. All right, hopefully everyone is seeing that. So again, thank you, Jessica, for that introduction. And a good afternoon or a good morning, depending on where you are, to everyone who's attending today. Dr. Seitz and I are very excited to be here and to be able to have the opportunity to share with you some of the information that we have about dealing with a very common but disruptive couple of behaviors in Parkinson's disease. So apathy and impulsivity. And what we'd like to do today, or what we're hoping to do today, is talk a little bit more about what these are, what to kind of look out for with these, and then some management tips and tricks as well for dealing with them. Sorry. All right, there we go, outline here. All right, so in terms of the just to orient everyone to our talk, we're going to first talk about apathy. We'll talk a little bit about what apathy is, how common it is, sort of what the manifestations are and potential issues or problems that arise with apathy. And then we also want to take people through some management strategies as well. So when you're identifying apathy, what are some ways that you can manage that? Another thing that we want to highlight is really differentiating between apathy and depression, because a lot of times, this is a question a lot of people have, How do you differentiate between the two? Because there's a lot of overlap in terms of the symptoms. So we'll talk a little bit about that as well. And then in the latter half of the presentation, we're going to talk about impulsivity and impulse control disorders. And similar to the structure with apathy, we'll talk a little bit about what are impulse control disorders, how prevalent or common are they, what are some of the things that you should be watching out for when there might be some concern for impulsivity or these impulse control disorders. And then again, sort of tips and tricks for how to manage them. Okay, so again, we're going to focus first on apathy. So apathy, again, is a fairly common symptom. Actually, it's a non-motor symptom in Parkinson's disease. And then although we kind of typically tend to think of Parkinson's disease as the motor symptoms that come with the disease. So the tremor, the rigidity, that kind of thing. We do know that apathy and other behavioral changes are actually quite common and contribute greatly to people's experience of quality of life. So quality of life is quite affected by some of these behavioral symptoms. We also know that the level of apathy, the amount of apathy that somebody might be experiencing, is associated with lower quality of life, higher disability, and higher healthcare costs in some cases. So traditionally, apathy was defined as sort of a lack of interest or a lack of enthusiasm or a lack of concern. But the definition of apathy has really kind of come a long way and been more refined in recent years. And it's now defined as more of an impairment in goal-directed behavior. So this impairment can come at the level of initiating activities. It can come at impairment at the level of planning activities. It can come at the level of being motivated to engage in activities in general. And there is also a recognition that apathy is likely associated with sort of a change in our sensitivity to reward and punishment, which we'll talk about is related to dopamine. So for anyone coping with apathy, this includes people, living with Parkinson's disease. This includes friends, family members, all of the above. For those coping with apathy, that this can be something that is quite frustrating and difficult to manage, because by definition, apathy is creating less of an inclination to kind of get involved with things, do activities, exercise, kind of follow medication schedules and that kind of a thing. So difficult to manage. So when we're talking about apathy in terms of how common it is, it's around 40% or so. So that's about an average. So a recent study in 2015 showed that there's a bit of a range, and that range is between 12 and to about 70% in terms of people living with Parkinson's disease and having symptoms of apathy. The range is quite high in part because we don't have a really good clinical definition of what apathy is, or a good way of diagnosing it, a set of criteria for diagnosing it. So it really depends on who's doing the measurement and how the measurement is occurring. But if we take an average, it's a fairly common symptom at about 40%. So in terms of risk factors, people who are more likely to experience apathy include people who have lower cognitive or thinking abilities and people who are older. And apathy is also associated with a number of factors that I mentioned a minute ago about kind of quality of life. So this includes reduced functioning in daily life. Apathy is associated with worse kind of illness outcomes and difficulty with treatment compliance, which, as you can imagine, difficulty with treatment compliance can then kind of create a vicious circle of increasing functional impairment and other kind of symptoms and problems in Parkinson's disease. And then apathy, not surprisingly, is also associated with an increase in care partner stress and sometimes burden or distress. All right, so we're going to take a minor sort of slight detour here and talked about facial masking or masked faces. So in terms of what we want to note here is that this is kind of in a related vein to apathy and in many ways to depression as well, which we'll talk about in a minute. But it's basically reduced expressionality. So facial expression, as we know, is an important part of communication. And when facial masking occurs, it can make it harder for people to show how they're feeling. It show their emotions, show their motivation, show their intentions. And this can be both in terms of showing sadness and anger, but I think an important thing to recognize too is that it can be difficult to express joy, express happiness, express interest, and that kind of a thing. And facial masking is often and not, or kind of understandably misinterpreted as somebody being disinterested or apathetic or sad or depressed. But that's not quite the full story. It's not to say people don't feel that way, but that the face may not be actually relaying what the underlying emotion is. So just like stiffness affects large muscles in arms, legs, and the core of the body, it also affects the smaller muscles that are in our face. So it makes it difficult to express emotion because the muscles just aren't moving the same way that they used to. So for anyone experiencing facial masking, again, this is another kind of frustrating aspect because others may assume that you're depressed or that you're disinterested. People might ask what's wrong a lot. And while it's never a bad thing to check in with people to see how they're doing, when you suspect they're sad, the facial masking is not necessarily a reflection of any kind of sort of current emotional or motivational state or reaction. It's just a symptom of Parkinson's disease and the overall stiffening of muscles. I do also want to say, I realize I missed saying this before, but with apathy on the last slide, want to note again that it's very frustrating, can be very frustrating for families and friends. But it's also just in the same way that sort of facial masking is a symptom of Parkinson's disease, apathy is also a symptom of Parkinson's disease. So it's just like tremor, it's just like slowing, it's just like stiffness, because it's related to those changes in dopamine that are occurring in Parkinson's disease. So again, important to note that apathy is not intentional, it's not volitional, it's not laziness, and it's not stubbornness. It's a symptom of the disease. So with that, I'm going to turn this presentation over to Dr. Seitz, who's actually here in the office with me. So bear with us as we kind of just do a little bit of seat changes, and he'll be right on.
Hi there, thank you, Dr. Polsinelli. All right, so I'll go ahead and pick it up from here. So as Dr. Polsinelli mentioned, apathy can be very frustrating for people with Parkinson's disease, caregivers, and their loved ones in general. But before I delve into tips here, I want to reiterate that it's important to understand apathy as a symptom of Parkinson's disease. It is not a choice or an unwillingness to participate in their care. In Parkinson's disease, dopamine is reduced, as has been mentioned a few different times, which is a neurotransmitter thought to underlie motivation. As such, the brain does not process motivation and reward normally. So with that said, I'll present some general tips for how to cope or deal better with apathy. First, it's important to ask for support as you try to be active and regain enjoyment in daily activities. It's important to lean on support and understand that you are not alone in managing your symptoms. Even if it does not feel helpful initially or worthwhile, it's equally important to keep at it, as any behavioral change takes repetition. One thing that has been very helpful, especially in my clinic, is creating a daily schedule as a way to create structure. In this way, you aren't relying heavily on the ability to initiate and plan, so it reduces that burden. It's also important to be realistic about what you can accomplish. Larger or unrealistic goals may only result in disappointment and reinforce the idea that it's better to simply not try at all. To compensate for changes in the brain and reward processing, it's also important to give yourself a small reward for each activity accomplished. An example might be a preferred activity such as a TV break, listening to music, or a phone call with a loved one. Another helpful tip may be to break larger activities down into discrete steps or actions. which creates more opportunities for success and may also make the task seem less overwhelming in general. Let's take laundry, for example. It's usually considered to be a singular chore, but can be broken down into many steps. First step is to grab a hamper, take it to the washer, put the clothes in, add detergent, etc. You may even want to list these out on a task card or a whiteboard to cross off each step as it is completed. I found with some patients for things that are more routine and more regular, such as laundry, one idea is to laminate a printed sheet with the steps out and use a dry erase so that you can use it again and continually cross that off as you complete it. So I'll switch gears here to general tips for increasing motivation. Again, similar to before, a daily routine is incredibly helpful. It may be helpful to keep a diary and check off aspects of your routine. It's inherently motivating to have a visual of what you have accomplished. It's also important to practice self-compassion as you're practicing new behaviors and strategies. Oftentimes, we are our own worst critic. Try to monitor this critic and try to insert phrases that promote kindness to yourself. I think a good rule of thumb is talking to yourself as if how you would talk to a friend that's maybe going through a hard time. Examples of self-compassionate phrases might include things like, my mistakes are not shortcomings and are signs that I'm growing and learning. It's safe for me to receive kindness and tenderness from myself. I forgive myself and my flaws because I'm human and everyone else is too. Practice makes improvement, not perfection. This is hard. I'm sorry that I'm going through a tough time. It's okay to apologize to yourself as you'd say to someone else. I'm going to give myself the love, the kindness and support I'm craving right now. I'm going to hold my own hand. I'm doing the best I can and so are most other people. This can reduce frustration with the self and others. There are plenty of other examples of affirmations that promote that kind of self-compassion, just available for free online, just with a simple Google search. Another tip is to practice curiosity and learn something new. Examples might include learning a new language. There are some apps such as Duolingo that are free for smartphones and devices. Art skills, free online classes, studying a historical event. Anything that keeps the mind engaged and is motivating. Another tip is to find purpose. And I think that's a very broad concept, but practically speaking, it usually begins with identifying your values. And there are even some value card sorts online available for free, but it's very motivating to have a daily purpose. And that can look different for a variety of people, something that gets you up and going in the day. Could be gardening, whether that be personal or a community-based garden. Could be volunteering or even caring for a pet. Another important thing is to practice letting go of old grudges, and this is of yourself and of others. It can free yourself to interact in more meaningful ways, live in the moment, and ultimately move forward. This kind of radical forgiveness is an active decision to let go of resentment. It doesn't erase the context or the past, but can ease the grip a bit. And it brings a kind of peace that helps you move forward and practice new behaviors and skills. This kind of forgiveness has been shown in the literature to lead to healthier relationships, improved mental health, less anxiety, stress, and depression, lower your blood pressure, strengthen your immune system, improve your heart health, improve self-esteem. A counselor may be a good option to assist you with this process to walk alongside and develop those values and that purpose to make sure you're moving forward and living the most meaningful values-based life that you can while you're coping with this disease. So my next slide, I'll talk about partner-assisted strategies for apathy. In other words, ways that you as a partner can support someone who has decreased motivation. First being praise accomplishments, and this is even the small ones. It's also important to mind the way that we praise, and that's to avoid being overly critical, as it may be taken that way. For example, persons with apathy or lack of motivation may find it difficult to venture out, go to a restaurant, engage in other activities, and saying, try praising with a phrase like, it was lovely to talk with you at dinner last night versus, wow, I can't believe you went to dinner last night. You don't usually do that. The former can reinforce or encourage the behavior, whereas the latter may instill guilt or shame. So it's important to praise directly and to be mindful of what you could be implying. It's encourage, always to be an encouraging voice and do tasks together like going for a walk. It's also helpful to facilitate the self-management strategy. So helping your partner with some of the ideas we've discussed previously. So the task card, setting up the journal, helping out with just starting some of those things. I'll now talk about treatment options. Of course, consulting your treating providers is most important, anyone that's prescribing you medications. While there are no approved medications to treat apathy, some medications have been shown to be helpful. And in fact, in 15 to 20 small studies, stimulants, dopaminergics, and acetylcholinesterase inhibitors were shown to be beneficial. This is an area that needs more robust research, certainly, but the results are promising at present. Counseling and behavioral therapy can also be helpful to understand the underlying barriers and develop more targeted strategies. Next would be regular exercise, restorative sleep, and social engagement. I really can't stress these enough. While we all know we should be doing these things, and I've probably heard it over and over again, the evidence really does not lie in the research. It has modest effects on mood and apathy, improvements in movement, memory, and overall well-being, and in general, abates the risk of cognitive decline, which is important for any brain disease. So maybe what some people are thinking as we go through, and Dr. Polsinelli touched on this a little bit, but the inherent difficulty is how do you get a patient, or how do you help a patient that is apathetic or lacking motivation, motivated enough to engage in these healthful behaviors that will ultimately improve the symptom or their quality of life. And I think that's where the framework of impaired goal-directed behavior is helpful in identifying where the breakdown is for a more targeted or selective intervention. Recall again that we now define apathy as impaired goal-directed behavior, which involves behaviors such as initiation, planning, and motivation. So if the breakdown is at the level of initiation, it can be helpful to set up alarms, reminders, things to get things started. Laying out preferred activities or materials to take out that initial step of having to seek that out can also be helpful. If the problem is with planning, being able to sit down and co-create a plan or schedule for the day, that also gives you a time with your loved one to spend some time and talk as well. If the problem is with motivation, oftentimes accountability is the most helpful here. So you're much more likely to go to the gym if you made plans with someone that's counting on you to be there. Knowing that a provider is keeping track, say, that you're bringing activity log to your next appointment, that kind of thing. And in general, just knowing that there's encouragement, support, and accountability. And I think this is a really important point too, that not all engagement needs to be active, particularly in more severe cases or perhaps later in the disease course. It's important to practice passive engagement. And that allows you to share in an activity or experience together that may bring enjoyment, connection, and overall just helps you feel more engaged and connected. It's important to know that this is still a beneficial and healthful activity, even if it's not the same as it used to be or feels the same. Passive engagement may include things like attending social events. Even if they're sitting alone and not speaking, it still allows the person to feel included without the pressure of needing to contribute. Another example is listening to the radio together, particularly if the song is tied to a memory or is sentimental in some way. It may provoke conversation or stories that otherwise would not have come to mind. Another example is just listening to you read aloud. In general, for ideas and troubleshooting these kinds of strategies and ideas, counseling and behavioral therapy may be a good route to implementing this, in addition to alleviating the burden or the responsibility of the caregiver, partner, or family. Behavioral therapy helps to understand the underlying barriers and develop targeted strategies like we've discussed. And that can be in the form of a psychotherapist, occupational therapist, and even a behavioral health consultant in some cases, depending on what's available in the setting. The goal, of course, being to increase physical, social, and cognitive engagement to increase motivation and overall health and brain health. So next, I'll talk about tips for family and care partners. Research shows that people with apathy tend to rely heavily on their family. Remind yourself that the person with Parkinson's disease is not necessarily making excuses or is unwilling. This is not something they're choosing. Take time for yourself, and I really want to reiterate this. I hear it time and time again in clinic that people feel like they're being selfish, but your health is incredibly important and completely necessary in order to provide the extra care required or what's being asked of you. Consider caregiver support groups as well, and other community resources. Sometimes there are respite services available where it can give you a few days break. Someone else comes into the home and can take care of the responsibilities that you're usually tasked with. Something Dr. Polsinelli mentioned that we want to touch on is differentiating apathy from depression. Both apathy and depression are common and yet distinct aspects of Parkinson's disease. Depression is a mood disorder, whereas apathy is tend to be thought of as a disorder of motivation. Starting with depression, depression can last from weeks to years and can occur at any stage of the illness. It can even precede other signs of Parkinson's disease, like motor as an early manifestation. Features of Parkinson's disease itself, things like bradykinesia or slowing, fatigue, disturbed sleep, flat affect, or a lack of reaction and or not expressing emotions in the same ways that others might, can be confused with signs and symptoms of depression. As you can see here with this Venn diagram, there is certainly overlap between depression and anxiety. If you look there in the middle, low interest, low enthusiasm, slowing, and low energy are both shared by the disorders. Depression may be distinguished by symptoms of persistent sadness or low mood, worthlessness, guilt, hopelessness, helplessness, pessimism, and even suicidal ideation or thoughts of death. She would not necessarily expect to be a part of apathy. Whereas apathy, again, we think of low motivation, low initiation, and perhaps just frank indifference, at least seemingly. Some other distinctions between apathy and depression. Apathy tends to increase with motor disease progression. So as motor symptoms worsen, apathy tends to increase. But interestingly, depression, when it was documented or reported, remained relatively stable, regardless of disease course, other symptoms, and severity. In general, apathy is higher with greater disease severity. So if those shared symptoms, as in the symptom overlap between depression and apathy, are worsening, may be helpful to first consider apathy, given what we know about the course and relationship between the variables. So why is it important to differentiate? Most obviously, it has different treatments, so it's important to differentiate from that respect. Additionally, an incorrect treatment may have negative effects. For example, studies have shown that common medications for depression may actually worsen apathy, and I'm thinking of SSRIs or the selective serotonin reuptake inhibitors. So if you're trying to target symptoms of depression, but it's actually related to apathy, symptoms may actually worsen. Whereas the literature suggested that other types of antidepressants were not associated with increased apathy, and thus may be a good treatment for either or both symptoms. Again, this would be something to discuss with your treating providers and care team. I'm going to switch gears to an additional symptom that can go along with Parkinson's disease. So we've covered apathy, and now we'll talk about impulsivity. Here I've provided the definition of an impulse control disorder, which will be abbreviated to ICDs on the following slides. An impulse control disorder is the inability to stop doing something that is harmful or could become harmful to yourself or others. Think of like malfunctioning brakes in a car. But beyond that, performing the harmful activity is believed to relieve anxiety and tension, which makes it so difficult to stop. In terms of the prevalence, the estimates are roughly 14% among those with a diagnosis of Parkinson's disease, meaning that it's estimated that 14% of those with PD experience an impulse control disorder. One of the most significant risk factors is treatment with a drug class known as dopamine agonists. Other risk factors include male sex and younger age of Parkinson's disease onset. And this may be because the higher levels of impulsivity exist at baseline, and so these medications exacerbate that. Baseline personality traits are also thought to be a risk factor, and it's important to know that impulse control disorders are not exclusive to treatment with dopamine agonists, and they can be a feature of Parkinson's disease in and of itself. So I'll go over some examples of some impulse control disorders. In gambling, this may take the form of gambling significant portions of life savings or retirement funds. It may look like making bets with friends and the inability to stop doing so. It may also look like purchasing excessive bingo cards, scratch tickets, lottery tickets, etc. Hypersexuality, this may look like demanding sex and becoming aggressive if denied, risky behaviors, infidelity, discussing sex at inappropriate times socially. I had a patient once too, just as an example of clinic, that would meet up at Walgreens and exchange gift cards for sex and had never exhibited any behavior similar to that before starting treatment. For eating, could see changes in eating behavior, such as eating in large quantities, gaining weight, making oneself sick, so eating to that point of discomfort and sickness. Hoarding, in the most classic sense, can look like the collection of items and or the inability to get rid of such items. Shopping, with shopping, often buying items that are unnecessary out of character, particularly ones that are excess in nature, so in large quantities. Another note about dopamine agonists. So a large study showed that the treatment with dopamine agonists doubled the occurrence of these behaviors relative to other patients not treated with dopamine agonists. For example, in this study, they did for a positive screen for any impulse control disorder, it was 24% in the non-treated Parkinson's disease population. However, that bumped up to 46% when a dopamine agonist was added. This twice as likely effect was seen across every single manifestation. So in a sense, doubling the prevalence or the risk. Sexual behavior and compulsive eating are among the most commonly reported of the impulse controlled manifestations. So next we'll talk about hobbyism and punding. This is a unique manifestation of an impulse control disorder, and the prevalence is about 20% while treated with dopamine agonists. What separates these behaviors from the other manifestations is that these behaviors are not necessarily new or perceived to be negative on the surface, but rather the issue is with the excessive amount that they're done that creates the problem. Or the possibility that things get ruined because you can't put something back together again. So it can cause a lot of damages as a result of the behavior. Punding, more specifically, can be defined as compulsive performance of repetitive mechanical tasks, such as assembling, disassembling, collecting, or sorting household objects. In both behaviors, it's often a fixation on pre-existing interests and involves an excessive focus on the activity to the exclusion of other activities. So for example, had a patient that was constantly folding clothes and unfolding clothes and instead of going to dinner or other normal activities. Another example was a patient that would build fences and would call all of his friends asking if they needed fences and would only focus on that versus and neglect other aspects of his health. Like other impulse control disorder behaviors, dopamine agonists tend to double the prevalence, and both hobbyism and punding occur about equally while treated with a dopamine agonist, though hobbyism was more common in the non-treated group of those with Parkinson's disease. Like apathy, it's important to note that impulsivity and compulsions are not a reflection of the person, but rather the disease itself and or the addition of medications. It is a direct result of the disease and medications, which can cause a person to not respond to consequences appropriately. The brain is not processing information normally. So practically then, what should someone watch for, especially someone that's close to a person with Parkinson's disease? People who experience impulsive or compulsive behaviors may not realize they have a problem, or stated differently, that their behaviors are problematic or harmful. It's important to understand that many behaviors are kept secret or may not even be apparent even to close family and friends. The person experiencing behavior changes may or may not experience distress and possibly may not realize the effects that their behavior will have. It's that breakdown of that risk and benefit, the reward consequence. NHS guidelines say that healthcare professionals, caregivers, and family members of people with Parkinson's need to monitor behavior over a long period of time. This is because these behaviors can develop sometime after treatment is introduced. In some cases, this can even be years. They can go years with the treatment without exhibiting these symptoms. If you're concerned about someone with Parkinson's disease, look out for any of the following signs. Have they recently put on weight? There may be a number of reasons for this, but you might want to look for the signs of binge eating. Someone may be eating large quantities of food, even when they're not hungry, in a short period of time and in private. They may be feeling guilty about their behavior. Are they being more protective than usual about their finances? Are they being more secretive, perhaps with phone calls or their use of the internet? Have they started collecting or organizing certain objects? Have you noticed them carrying out tasks repeatedly? Are they going shopping more often than usual? Are they spending more and more money, or have they started to lead a more expensive lifestyle than before? Are they spending more time than usual on their computer, phone, or tablet, perhaps on shopping or gambling websites or websites with sexual content? This may be during the night or even the early hours of the morning, so you may not even be aware that this is happening. Online services have made it much easier to engage in compulsive shopping, gambling, and sex than it used to be. Further, if the person with Parkinson's disease is your partner, have you noticed an increase in their sex drive or a change in their sexual behavior, either towards you or anyone else for that matter? Another thing to look for is, are they taking more of their Parkinson's medication than they should? Have you noticed an increase in aggressive behavior? Are they more restless and irritable than usual? So what to do if you do notice these behaviors? If you notice changes in behavior, talk to the person with Parkinson's disease and get support from their healthcare professional. A medication review with their doctor is often a helpful and first step. They may decide to decrease or stop the dopamine agonist altogether. A cost-benefit analysis may be warranted if the medication is beneficial. So for example, if the dopamine agonists are decreasing apathy and outweighing other risks. This may shift management of symptoms to a preventative or a compensatory approach, trying to reduce the harm. Examples of that kind of a strategy may be taking over finances, at least temporarily, by way of limiting access to their money, blocking their credit, etc. You may want to discuss non-pharmacological solutions, such as a deep brain stimulation procedure. Here at IU, neuropsychology has a large role in the pre-surgical evaluation for these patients. And oftentimes we see they do find relief from this option. By lowering motor symptoms through DBS, medications often can be reduced depending on the level of relief, which does have some downstream effects as well on reducing some of the unwanted side effects of the medication, things like impulsivity, brain fog, etc. Psychotherapy and support groups may also be helpful to identify triggers and address urges in a constructive way, and to help the person not feel alone in dealing with these symptoms. Adding medications or otherwise a pharmacological option is also an option, but typically a last resort for the management of impulse control disorders. So here are some considerations for managing impulsivity. It is so important to exercise patience, and that's because it may be up to 4 months until impulsivity symptoms go away after discontinuing a dopamine agonist. Again, practice self-compassion. This is important because once insight is gained into these behaviors, there will likely be guilt and remorse. Due to the timeline, may also be wondering why they are still behaving in certain ways without the medication, which can lead to more guilt, remorse, or shame. This is another viable route for something that psychotherapy can help target as well. Finally, do not be afraid to reach out. Once a behavior is started, it is very difficult to stop, and that's not uncommon. It's important to not be afraid to ask for help. I'll conclude with some take-home points. Motivation and apathy problems are one of the many neuropsychiatric difficulties seen in Parkinson's disease. Apathy is common and difficult to manage, but does respond to self, partner, and medication interventions. Impulsivity is a risk with treatment of Parkinson's disease, especially if using dopamine agonists. These symptoms are not a reflection of the person, but are a direct consequence from Parkinson's disease and the associated changes in important neurotransmitters. Finally, keep your doctors informed of behaviors reflecting apathy and impulsivity. Thank you very much.
So much to the both of you. We're just waiting for Lindsay to go in. There she is. Great. Welcome, Lindsay.
Hello, everyone. My name is Lindsay Shanklin. I am the Center Coordinator and Social Worker of the Parkinson's Disease Center of Excellence at IU Health. I'll be moderating the Q&A today. I'd like to welcome back all of our presenters, and then we'll get started. Is that everybody? think so. Okay. We will start with a question about research. We'll start with Dr. James. How can I get involved in research?
Good question. So here at IU, the study that I mentioned, that's one obviously that we're doing. It's a drug trial. And so that's one way you can get involved. But making sure that if you're a patient here at IU, that you let your doctor know that you are interested in research, because there's, we have studies that are coming and going kind of all the time. And so just make sure that you let your doctor know that you're interested in research. Another good way to get involved is by going on the michaeljfox.org website. And on that website, you can enter your information, your name, and they ask you some questions, and then they're able to kind of to help facilitate getting you involved with research that way as well.
Okay. Another thing I'd add is that Lindsay has put together an email newsletter. So we're going to use that to let everyone know about educational events that are coming up, but also about new research studies. So I think when you registered for this conference, you had the option to opt into the newsletter. So keep your eyes on that as another way to find out about new things happening here.
Yes. All right. The next question will be for Maggie. What are the benefits of mindfulness?
That's a great question. Yeah, so there's been a lot of research in the last probably decade or more on how mindfulness is helpful for your emotional state, for the brain. It can kind of help you to tolerate pain longer, or tolerate a sense of uncertainty without the anxiety that accompanies it if you haven't practiced mindfulness. And art therapy and mindfulness can definitely go hand in hand. You can color mindfully, or do mindful art making, or mindful squishing of clay. There's lots of things you could do. And I know the Parkinson's Foundation has done quite a bit on mindfulness too. So I bet Jess has some information she can share there. Thank you for asking.
Thank you. The next question will be either for Nina or either Dr. James or Dr. Zauber. How do I reduce dry mouth?
Oh, I'm sorry, if one of the doctors want to answer that.
So dry mouth can be a side effect of some medicines. So if somebody's taking a medicine that causes a lot of dry mouth, then potentially going off of that medicine could be a way to reduce dry mouth. The most common culprits that we use, one is amantadine. Certain bladder medicines can cause dry mouth. Sometimes the mouth is dry because it's just staying open when people sleep, or even during the day. So potentially trying to find ways to keep it closed more. Maybe people use chewing gum or something of that nature. Humidifiers at night. There's a lot of over-the-counter products that are out there for dry mouth, like Biotine mouthwash and Biotine toothpaste. Sometimes those are helpful for people. There is no real pharmaceutical agent that we use to add to somebody's medication regime to lessen dry mouth, unfortunately.
Thank you. Hilary, in your presentation, you made reference to functional task practice. What exactly is that?
Yeah, so with LSVT Big, every session, so it's like 4 days a week, the therapist will give you a homework to do at home, and that includes something functional that we've already discussed and kind of established goals for. So for some people, it's like taking their coat on and off. That could be really tricky because getting the arms out of the sleeves. It could be, walking out to the garage, getting in your car. It could be like stepping up and down a curb or doing stairs. It can be a wide variety of things like brushing your teeth or even a piece of that movement, but it's something that we'll have you do that day and practice it so many times that in the way that we teach you to practice it at home. So then you'll come back the next day and we'll ask how it went. Or if you're going out to eat or doing something that evening, we may ask you to incorporate some of our training techniques while you do that activity. So that's just what that means.
Great, thank you. This would be to Dr. Seitz and Dr. Polsinelli. What is the best way to cope with hallucinations?
Yeah, so that's something we didn't quite touch on today, but can be a side effect of the dopamine agonists. And I think probably Dr. Zauber, Dr. James could speak to that a little bit more directly. However, in terms of the actual coping, I think it's important not to provide a lot of active resistance with the person experiencing it, as it is distressing and can only cause conflict and more irritation. And then ultimately consulting with a treating provider to see if there's any kind of medication or atypical antipsychotic that could be added to help out with those symptoms, or decreasing the medication as well. Anything you want to add?
No, I completely agree. I think the biggest thing is just not to be confrontational about it. Sometimes you don't want to necessarily confirm either the hallucination. And so part of it can be a little bit of a redirection of a validation of the experience of, yeah, I know you see what you're seeing, or I know you hear what you're hearing. I can't see it and I can't hear it, but it sounds like, maybe it's important, or maybe it's distressing, and it recognizing the emotion or the potential motivation for, or the potential expression of the emotion that might be coming through with that hallucination.
Great, thank you. Dr. James, what is a rescue med and how long does the effectiveness of the rescue med last?
Yeah, a rescue medication is a dopaminergic medication that tries to get you quickly out of what's called an off time. So previously I mentioned sort of the difference between on times and off times. These are usually for our patients that fluctuate quite a bit from a day-to-day, from an hour-to-hour basis. And so people eventually, after having Parkinson's disease for some time, they tend to have more of these fluctuations. And if someone were to go in suddenly to an off state, meaning that means somebody is suddenly kind of stiffer or slower or harder to kind of get around or move, there are now a couple of medications that we can use that are kind of considered as kind of like a rescue medication. So before we would, be telling people, and I still do this, that you can grind up or chew up a tablet of Sinemet or levodopa. That's one way to kind of get it in your system a little bit quicker. But now we have the Kinmobi, the sublingual film, and then we have the Ambrosia inhaler, which are kind of more, are newer options for us that can help people get out of those off times. So that's what I mean by a rescue medication.
Mm-hmm. All right, thank you. Dr. Zauber, I'm going to direct this question to you. what if I don't have a huge support system, no spouse, few family around, I'm by myself?
That is a difficult situation. I agree. It's tricky to manage a disease as complex as Parkinson's entirely on your own, especially after more years have gone by and the disease becomes more complicated to manage. So you're right. Not everybody does have a partner or even family members or even friends. I think my advice is generally always to try and reach out to someone who does care about you and let them know that one way they could help you is to maybe come to doctor visits with you or take you places or just be willing to reach out to them and ask for help. I know that there was an initiative that was sponsored by the Parkinson's Foundation. I think it was in New York City. That was a program for people who are single, don't have partners, don't have care partners, but are living with Parkinson's, for them to connect. And that was a nice program because it acknowledges the fact that, that people aren't alone in being in that position, and trying to provide some support, especially virtually during the pandemic, for that group. So that might be something that Jessica can also provide more info on, since that was a Parkinson's Foundation project.
Yeah, I'd like to speak to that a little bit, Dr. Zauber. So I can't think of the name exactly of the project because there's many that we're involved in, but we definitely can send in our follow-up email for this person. We will include some information, and one of those is about the program that I had mentioned at the beginning that's coming up next week. So that program is focusing on people who are don't have maybe this full support system, or maybe they're living alone for one reason or another, but it's basically called PD Solo. So we're going to explore that a little bit. The program, like I said, is Wednesday, and we will send information on how to register for that. It is parkinson.org/PD Health, and it's under the Wellness Wednesday. We are also going to have another webinar in September, also geared toward people who are living alone with Parkinson's. So, and there was a grant that did work with people in, I believe it was on the East Coast, Dr. Zauber, and I wish I could remember it exactly, but that might be the one that will be speaking with us next week, actually. Her name is Lissa Kapust, and it was a great program. So there are ways to get involved. And also, I always encourage people to join a wellness group for Parkinson's or a support group if you can. Also call our helpline. I'll put that information in the chat. But there's also the Fox Buddy Network, which is a really great tool as well. So you can just, we'll put that in the follow-up email as well, but you can just kind of Google that, and it's a great platform for meeting people and finding support that way. So hopefully that's helpful.
Awesome. Thank you both. This question is going to be for Dr. James. I have 5 children, and I'm interested in them taking the SYNTAP test. Can my neurologist perform and schedule that test? At what age should they take that?
Good question. I think as just a general rule of thumb, especially now, we don't have any definite known proven disease modifying therapies. And so I'm always a little hesitant to do testing on children. It doesn't really change anything at this point. Maybe in the future, once we have known disease modifying treatments available, it would make a little bit more sense. But just in the realm of genetics and testing children, I think I would always be afraid of instilling sort of a stigma with certain children that may come back as having sort of a positive test, and then not really knowing exactly what that may mean for the child. You know, is that something that's ultimately going to mean that they have Parkinson's disease when they're 40 years old or not? So it's just, I think it just adds to the confusion. So I wouldn't use the test, at least for that way at this point. But I think it just means that, you know, there are some available tests that may help us down the line, especially for our adult patients. I don't know if that answered your question, but I would be, Liz, I don't know if you think about it differently, but I guess that's how I would approach that.
Okay. And then would the neurologist schedule that if somebody was interested in getting that done? Is that a research thing?
Yeah, so I think eventually it's going to be part more of research projects, but yes, it's something that the doctor would be able to do. It's something where we would be able to contact the company and then and get that done. Again, it's not FDA approved yet, so it would be kind of expensive to do. And again, most of the time, this is not necessary in order to establish a diagnosis of Parkinson's disease.
Thank you. Maggie, you said the Find Your Groove program was funded through a grant and had no cost to the participants. When would the cost of art therapy for PD be paid by Medicare? And if it's not, how much would it cost to a patient?
Those are great questions. So in the neurology clinic, our art therapy program at IU Health is currently at no cost to patients, regardless of what insurance you might have or not have. We do have a wait list currently, but if you're interested and you're an IU patient, you can contact me at the email that I provided earlier, or you can call the number for our clinic and participate. In other locations, if you have Medicare and you find a therapist who is able to accept Medicare, then that art therapist could help you there. But art therapists around the country tend to have costs that are similar to psychotherapists, to talk therapists, and take various insurances, or may have sliding scales. So what I'm answering for is specifically our program at the Neuroscience Center, but right now it's at no cost to patients, and that way also loved ones can participate. So caregivers or care partners and family members. So I hope that helps.
Oh, awesome. Thank you. Follow up to that. Will the art therapy classes planned for the summer be virtual or in person?
They would be virtual probably. Yeah, so that we could open it up to people around the state.
Great.
So yeah, you can again contact me that same way if you're interested.
Okay. Nina, Hilary, Ryan, how many times can I enter the LSVT programs? Meaning, can I do it more than once if I feel like I need a refresher?
I can answer that. It is unlimited as far as I know, but usually after one session, we take a break and see how you do. But a lot of times, we do bill insurance, so that can be the barrier within a year. I don't know that many patients, would be able to do it more than once a year, but we definitely could.
And I would add to that as well is that before discharge, we establish a home program as well. So to help you maintain your goals, or help maintain your progress that you made in therapy. So we definitely established that home program. And then, it is not uncommon to need a refresher at some point. But I think like Hilary said, that sometimes is dictated by insurance. So perhaps, once a year would be appropriate.
Okay. Thank you.
Just to add to that, I was going to say with the, you know, having that established with your therapist, then obviously that ongoing conversation, you know, technology allows us to be available either via, you know, telephone or email. Like if they have been doing these exercises, you know, just having that online communication, and if for some reason or open communication, we could easily address those needs. And then obviously when you have that follow-up with your physician, you can bring those needs up as well and see what else could be done on a therapeutic level.
Okay, thank you guys. This next one will be for Dr. Seitz and Dr. Polsinelli. Are there specific activities that will allow my brain to produce more dopamine or a longer duration of producing dopamine?
I would say anything that is personally rewarding or motivating, but I would not, I want to stay in my lane too, that I don't know of certain activities that will specifically target that aspect of the brain. But I would just say more in general, the activities that you can do that are rewarding, that bring pleasurable feelings, and anything that creates new learning and new connections is just good for your brain health in general. But no, I wouldn't say there is one specific activity to target dopamine itself.
Nope. Do the things you like. Do the things that you like that keep you stimulated, that keep you, you know, content, excited, that bring you maybe not full on joy, but if you can get to that, that'd be great. So just doing those activities that nobody needs to force themselves into doing an activity that they don't like to do, like crosswords or Sudoku or something. I don't know. I'm not a big fan of those. I'm very bad at them. So, you know, find the activities you enjoy doing. There really isn't an activity that's better than another.
Okay, great. Thank you. Dr. James, this person said, I want to participate in the clinical trials that were mentioned, but it's about a 4-hour drive to the closest site. Would the distance be a problem when considering my eligibility for trials?
Good question. It is a barrier to a lot of patients getting involved with research. So depending on the type of trial, each trial is going to be different in terms of what's required, in terms of you know, how often you'll need to come in and have visits. So it kind of depends on the particular trial. I will say that a lot of the sponsors and trials that we do, a lot of them have, we're able to reimburse patients that make long trips. And so oftentimes you can get reimbursed for travel expenses and sometimes even hotels. So that's also a possibility. So it kind of depends on the trial itself and what's required. But then again, each trial is a little bit different in how it helps the participants.
Okay, awesome. We'll do 2 more questions. This one I'm going to direct to Dr. Zauber. If you have a PD gene, will you get PD?
Great question. Yeah, so the short answer is not necessarily. So that's one reason why in the past we didn't do a lot of genetic testing in people, is that we said, okay, if we have someone in front of us who has Parkinson's and we do genetic testing, statistically speaking, chances are, even if they have a family history, they're still going to test negative for any of the genes that we can test for. But if they do test positive for a PD gene, then their family members might be curious to get tested. Adult children might say, I want to know if I carry that gene. And the adult children could get tested, but even if they do carry that gene, it doesn't necessarily mean that they will go on to develop Parkinson's. It just means they have an increased risk. So that's one reason why in the past we often did not suggest genetic testing to people. The reason we're starting to recommend more genetic testing and this PD gene study is going on to allow people to get free genetic testing is because of some of those trials that Dr. James mentioned, where if people carry a specific gene, LRRK2 or the GBA gene, that there are ongoing clinical trials enrolling people with those genes. And we're hopeful that if those trials show benefit and it's slowing the course of the disease, that ultimately we would want to find people who carry the gene but don't yet have Parkinson's.
Okay, thank you. All right, we'll do one last question and we'll close it out. I think this will also be for Dr. Zauber. I would like to know more about Indy's COE and its professionals. It's only about an hour away, but our community in Bloomington knows very little about it. I'm excited to learn about the resources. How can I do that?
Yeah, great question. I think I know not everybody who's on lives in Indiana, but I'm assuming many of you guys do. And being a center of excellence means that we have this really broad team, many of whom you're seeing here today, of people who have expertise in caring for people with Parkinson's. And we have 4 movement disorder neurologists. And so people who come here can get a high level of care. They can get all of the different types of treatments that people with Parkinson's need. The other thing that being a center of excellence means is that we are doing education and outreach to the community. So one way we do that is through these symposiums. We also run Parkinson's 101 classes for people who are newly diagnosed. Lindsay runs a care partner support group. So we are trying to serve the Parkinson's community in that regard, and not just through the one-on-one clinical care. Lastly, we realize that not everyone can come to Indianapolis for all of their visits. And so, one long-term goal that we have is to create a really robust network across the state so that we could say, okay, you have Parkinson's, you live in Bloomington, maybe you come here for a one-time consult and see us, and then we can help direct you towards resources locally. Maybe that we know of therapists there who have special expertise in Parkinson's, for example. So we'd like to sort of develop a lot of little mini centers of excellence across the state, perhaps Lafayette, perhaps Evansville, maybe Bloomington as well. So that's kind of a long-term goal. But we realize that even though it's wonderful that we have all these resources here in Indiana, we certainly can't see every Parkinson's patient in the state for every visit, and not everybody can come here for, for example, for their physical therapy, even though they would get really good care.
Okay. All right, that now concludes our program. I want to thank all of the wonderful speakers who provided their time and expertise today, but most importantly, to all of you in the Parkinson's community who continue to inspire us. Don't forget to fill out those evaluations and be well and enjoy the rest of your weekend.